Hello, this is Dr. Zhang. Now let's review myelodysplastic syndromes. Here are the objectives. MDS is featured as progressive cytopenia despite cellular bone marrow and dyspoiesis of one or more cell lines, that is, defects in erythroid, myeloid, and or megakaryocytic maturation. So, the two key features of all MDS are cytopenia and dyspoiesis, all because of proliferation of abnormal stem cells at the level of the myeloid stem cells. It can be primary, caused by chemical insult, radiation, or viral infection. It can be secondary to chemo or radiotherapy. The median age at diagnosis of MDS is 70 years old. Let's look at the three cell lines affected in MDS. First, the red cells. In peripheral blood film, overall macrocytes is the most common finding. MDS should be suspected if there's no vitamin B12 or folate deficiency. Hypochromic microcytes are also seen. That's why we call it a dimorphic red cell population. You can see both types of red cells from the blood smear on the top left. In bone marrow, the red cell precursors can have more than one nucleus, or the nucleus have abnormal shapes such as bilobe or buds. The image on the bottom left shows erythroid hyperplasia. You can see budding of nucleus. The image of the bottom right shows internuclear bridging. Ringed sideroblasts are a common finding. This myelopoiesis is featured as persistent basophilic cytoplasm. The cell look mature, but cytoplasm stand basophilic, as shown in all three images. Abnormal granulation, it can be no granules at all, as shown in the image on the top left. Abnormal nuclear shapes, as shown in the image on the bottom left. The nucleus forms a ring, and uneven cytoplasmic staining, as shown in the image on the right. This megakaryopoiesis is evidenced by giant platelets and abnormal platelet granulation in peripheral blood, as shown in the image on the top left. Circulating macromegakaryocytes can also be seen, as shown in the image on bottom left. The image on the right shows abnormal nuclei of megakaryocyte. All the morphological abnormalities we have discussed so far come with abnormal cellular function. MDS has to be differentiated from other disorders that have similar morphological features or dysplasia, such as vitamin B12 or folate deficiency, exposure to heavy metals, copper deficiency, parvovirus B19 infection, and some congenital disorders, including Fanconi anemia and congenital dyserythropoietic anemia. Both FAB and WHO classification are still used. For this class, let's just be familiar with the names of WHO MDS classification. They are refractory cytopenia with unilineage dysplasia, RCUD, refractory anemia with ringed sideroblast, RARS, refractory cytopenia with multilineage dysplasia, RCMD, refractory anemia with unilineage dysplasia, RAEB, myelodysplastic syndrome with isolated DEL5Q or 5Q syndrome, myelodysplastic syndrome, unclassifiable and childhood myelodysplastic syndrome. Pay attention to ringed sideroblast definition, as we are the ones that need to identify them. To be qualified as sideroblast, the erythroid precursor must have more than 5 iron granules, and those iron staining granules must circle at least 1/3 of the nucleus. A group of neoplasms share the features of both MDS and MPN. There are 4 disorders in this group. They are chronic myelomonocytic leukemia (CMML), atypical chronic myeloid leukemia (BCR), ABL1 negative, juvenile myelomonocytic leukemia, and myelodysplastic myeloproliferative neoplasm, unclassifiable. So just a few names, and we will not get into the details of any of them. Let's look at CMML as an example. Among the 4 features listed here, can you see both MDS and MPN features? If not treated, MDS most likely converts to AML. The scoring system listed in this table here can help us predict the prognosis of the disease. The scoring system is based on 3 things: number of blasts, chromosome abnormalities, and cytopenia. The cytopenia is defined specifically in this case is based on hemoglobin level, neutrophil, and platelet count. Why we take so much pains to figure out the prognosis, as it determines how the patient can be treated, which you may read at your own leisure. Supportive treatment is used for most patients with MDS, especially the one with favorable prognosis. Chemo and biological response modifiers have limited success. Right now, the only cure for MDS is bone marrow or hematopoietic stem cell transplantation. That's the end of this review. Thank you very much for your attention.